Vijayan sir, Dr. Johnny sir, Dr. Anandakeshavan sir, Dr. Purushothaman sir, Dr. Sushma madam, Dr. Binu sir, welcome. And I request Dr. Nandakumar sir to give the presidential address.
Yeah.
Thank you, sir.
Good evening, all. Respected President IAP Kochi, Dr. Vijayan sir, Secretary Dr. Satyajit, PG Coordinator Chairperson Dr. Mohandas, Dr. Shanavas, senior members Sushma Madam, Anandakeshavan sir, Purushottam sir, Darli Madam, and other dignitaries on this platform. Today, at the outset, let me congratulate IAP Kochi for hosting today's PG teaching program. And today we are going to discuss a case of autoimmune hemolytic anemia, and the faculties are Mary James and mentor, my own classmate, Dr. Johnny, and Dr. Tansi is the presenter. And over to Dr. Sachet for further proceedings. I wish all the very best for this program. Thank you.
Thank you, sir. Thank you so much, sir, for your address. I request Dr. Vijayan sir, our IAP Kochi president, to say a few words.
Good evening to all. Today we are very glad to be with you with the PG teaching program. So first of all, I thank you all the dignitaries and office bearers of the Kerala IAP, Dr. Nandakumar, the IAP president, Dr. Gobi Mohan, the IAP secretary, Dr. Binukutan, the treasurer, and also Dr. Mohan Das of the state coordinator of the PG teaching program, and the Shanavas of the scientific coordinator, and Dr. Sunil Daniel, zonal coordinator. I am very glad to introduce our eminent faculty, Dr. Mary James of GMC Kalamassery. So our presenter is Tasmi Tansi. Dr. Tansi is here, eagerly waiting to present before you the topic of hemolytic anemia. Once again, I am thanking all of you and all the dignitaries here. And without wasting any time, I am without wasting any time, I convey.
Invite
the coordinator to continue the session.
Thank you, sir. Thank you so much, sir. So over to Mohandas, sir, for a few words before we start the case.
Hello. Good evening. I'm very happy to be part of this program. And I think there is no need for any such speech here. Regarding Dr. Mary, I know her as from the time she joined in medical education in Alleppey, and I am also very eager to hear her. Thank you.
Thank you, sir. Thank you so much, sir. With permission of all the seniors and colleagues here, shall we start the case presentation? In that case, we request Dr. Tasni. You can start your presentation. You can start your slide sharing.
Am I audible?
Yes.
Yes, yes, yes.
Good evening, everyone, respected professors, senior doctors, residents, and all my dear colleagues. Myself, Dr. Tasti. I'm doing secondary DNB first year in Medical Trust Hospital. First of all, I would like to express my sincere gratitude to my mentor, Dr. Johnny Wagil Francis, sir, for helping me out to present this case and for being a very good support throughout my preparation. So without wasting much time, I would like to move on to my presentation. Shall I start, sir? Hello?
Yes,
Yeah,
you
yeah,
may
yeah.
start. Please continue.
So here we had a case named SF, 8-year-old girl child hailing all the way from Perumbaur. Informant mother, reliable. Date of admission was on 28th January 2026. Date of examination, same date, 28/1/2026. She presented with complaints of fever since 10 days, EC fatigability since 10 days, bilateral swelling over the neck, more on the right side since 10 days, passage of cola-colored urine since 4 days, progressive pallor since 4 days, and palpitation since 3 days. History of present illness. An 8-year-old girl child, apparently well 10 days back, now presented with complaints of bilateral swelling over the neck and fever, more on the right side of for 10 days. Fever started as low-grade intermittent and it was gradual in onset. After 4 days of fever, the low-grade fever gradually turned to high-grade intermittent associated with chills and rigor. It was not associated with cough, cold, dysuria, throat pain, vomiting, or loose stools. Mother also noticed swelling on both sides of the neck, mainly on the upper part of the neck below the ears. It was not painful to touch and there was no redness or discharge from the swelling. She also gives a history of EC fatigability for the past 10 days. The child gets easily tired on doing routine activities and she prefers to sit or lie down and show decreased interest in outdoor activities. It was progressively getting worse. And mother also reported that child was passing dark cola-colored urine for the past 4 days, especially during night. It was not associated with dysuria, flank pain, or increased frequency of urination, or there was no visible clot in the urine. She also noticed that child was looking very pale for past 3 to 4 days and it was increasing in severity. There was no history of jaundice noticed by the parents. Child also complains of awareness of fast heartbeat for past 3 days, especially after playing, and it gets relieved on taking rest. She consulted in a local hospital on the very second day of illness and they were prescribed antipyretics and topical medications for the swelling. She was again seen at local hospital on day 4 of illness and blood investigation done from there was told she had decreased platelet count, however other blood reports were normal. She was prescribed an oral antibiotics for 7 days along with antipyretics.
Okay, Tasneem, can you tell the causes of neck swelling?
Hello, ma'am.
Fever and neck swelling. What can be the causes?
If it is like bilateral swelling, it could be due to some scarlet fever, lymphadenitis,
Okay.
and TB,
Most of the time it will be a lymph node.
lymph node.
Okay. What
Survival.
others can it be?
Then brachial cyst, ma'am,
Brain kills.
or lymph.
More common than that?
Parotitis, ma'am.
Lot of children are having mumps, no?
Mumps.
So can be salivary gland swelling, inflammation of the salivary gland, sialadenitis. So first is always lymphadenopathy. More than 95% of the case, it will be fever with cervical lymphadenopathy. It is there in the upper part of the neck, you told. So if it is cervical lymphadenopathy, which level lymph nodes?
Level jugular lymph
Clinical level classification, it is level 2.
level 2.
Level 2, that is upper jugular. Why you should know the levels? you should be looking for a focus in the drainage area.
Okay.
So level 2 is upper jugular. Where all will you look for any lesions if there is level 2 lymphadenopathy? Level 2 is upper jugular.
So,
Of course, from level 1, it will receive drainage. So you will look for lesions in the face, the mouth, then salivary glands, external auditory meatus, oral cavity, oral cavity, oropharynx, nasal cavity. So these are the areas which you will be looking for if you get this group of lymphadenopathy, level 2. Because you told swelling is in the upper part of the neck. Okay. So if it is not a lymph node, then the next common is salivary gland.
parotitis.
It may be, you told it is bilateral. Then you told it is
More on the right side.
branchial cyst, branchial cleft cyst. That is what you told. If it is a branchial cleft cyst, which type can it be? Which type means from which cleft? Second branchial cleft cyst. Where does the first occur? Second will be in the upper neck. First, branchial cleft anomalies can be seen as either sinuses or cyst. So the first will be between the ear and the angle of mandible. The second will be in the upper neck. Sometimes what will happen, this branchial cleft cyst will remain silent, asymptomatic. Sometimes during an infection, it will get enlarged. That may be the first time parents notice a swelling. And also during respiratory infections, this can get enlarged. So, because you told branchial cleft cyst, I was telling. So first branchial cleft anomaly, maybe a sinus. It is a differential diagnosis of
Unilateral.
there is a sinus.
Yeah. But it is
Near the ear. What is the differential diagnosis? Preauricular sinus, no? Preauricular sinus. What is the difference between preauricular sinus and first branchial cleft anomaly? Sinus, because of that. There is a difference in location. If it is a preauricular sinus, usually it will be anterior to the ear and at or above the tragal level. So any sinus which is below the tragal line, it can also be retroauricular, below the tragal line, near the angle of mandible, we have to be a little more careful because it can be a first branchial cleft anomaly. The importance is preauricular sinus is something superficial, but branchial cleft anomaly, sinus due to that, is going to be a deep one with intimate relationship with the parotid gland and facial nerve. So, while doing surgery, it will be difficult. Sometimes parotid also will have to be removed. That is the importance of differentiating between these two. Because you told about branchial cleft cyst, I was telling. Okay, this has no relationship with this case. We'll continue. Okay, you can continue now.
However, the fever persisted and she developed cola-colored urine on day 6 of her illness, and hence she was admitted in a local hospital. The blood test done from there was said to have a rapid fall in hemoglobin, and the platelet counts were reported as normal. She was given an injection of antibiotic for 2 days and then referred to our hospital. There was no history of hematemesis, melena, hematochezia, diarrhea. No history of abdominal pain.
Tell why you have asked for these negative histories.
To rule out any
Tell
gas.
one negative history and tell why you have asked for it.
Okay, ma'am. There was no history of hematemesis, melena, hematochezia, diarrhea to rule out any gastrointestinal bleed. No history of abdominal pain, pain in limbs, bone pains to rule out leukemia. No history of convulsions or hemiplegia to rule out the vaso-occlusive crisis in sickle cell anemia. No history of hematuria, pica, constipation to rule out iron deficiency anemia, hypothyroidism. No history of passing worms in stools, visual disturbances. Worms mainly the worm colic infestation due to hookworms, and visual disturbances. I asked for osteopetrosis. No history of any other drug intake rather than the prescribed medicine from hospital. No history of oliguria, polyuria, or nocturia to rule out any chronic renal diseases. No history of pedal edema. I asked to rule out any congestive cardiac failure causes. No history of arthritis or arthralgia to rule out juvenile
Breathing
idiopathic
difficulty. That
arthritis.
is fine.
Hello, ma'am.
Because there is breathing difficulty, you ask for history of any cardiac problem.
Yeah.
Yeah.
No history of periorbital puffiness in acute glomerulonephritis.
Arthritis for arthritis,
Juvenile,
arthralgia.
juvenile idiopathic arthritis, ma'am. It's a chronic illness where we get to see the arthritis and anemia. No history of previous anemia or blood transfusions to rule out thalassemia, leg ulcer, sickle cell anemia. No history of recent weight loss or chronic cough to rule out TB.
No history of previous anemia or blood transfusions or leg ulcers to rule out
Hemoglobinopathies, ma'am.
like
Thalassemia, sickle cell anemia,
which thalassemia?
thalassemia major.
This is an 8-year-old child, no?
Yes, ma'am.
Okay.
No history of constipation, weight gain, or cold intolerance to rule out hypothyroidism. No recent history of travel. Hello, ma'am.
Why did you ask for hypothyroidism?
Hypothyroidism can also have anemia.
Due to? Okay, autoimmune thyroiditis can be an association, no? In this case, autoimmune thyroiditis.
No recent history of travel to endemic areas where malaria is seen.
Okay.
No history of contact with very viral illnesses.
For?
To rule out some viral infections can also produce this autoimmune hemolytic anemia, like
Which are the viruses mentioned?
Epstein-Barr virus, then CMV, then mycoplasma pneumonia.
Mycoplasma viruses, other
No,
viruses?
viruses, EBV, CMV.
Then?
Uh,
Which are the viruses mentioned in Nelson?
HIV, adeno.
Yeah, I didn't know that. Then mumps, measles, rubella, varicella, coronavirus, H1N1.
Shall I proceed?
Okay, proceed.
Past history. She had history of hospital admissions for recurrent fever and cough 3 times at 2 to 3 years of age. There is no history of jaundice or similar illnesses in the past. No history of transfusion, oliguria, or anuria. No history of puffiness of face in the past. No history of blood in stools. No history of chronic cough, and no history of contact with TB patients.
Okay, can you summarize and tell the differentials?
Ma'am, here the child presented with acute onset of anemia following fever.
And swelling in the neck.
Hello?
Followed by child had fever and swelling in the neck.
Swelling in the neck, followed by child passage of cola-colored urine. So it is like an acute onset. So it could be due to some viral infection-induced autoimmune hemolytic anemia, or
So
it
your first differential diagnosis is
autoimmune
AIHA.
AIHA.
Okay. Then what
Or
type of AIHA? If you think of AIHA, what type?
it could be, ma'am, cold agglutinin disease.
Mm.
So most common is warm, but
What
the
percentage is cold? What
percent,
percentage TAD, cold agglutinin disease? What percentage is TAD, cold agglutinin disease is only up to 10%. Okay, up to date tells it is only up to 10%. 60 to 90% of the cases are due to warm, warm autoantibody.
So one differential diagnosis is
So
AIH.
first differential
Second,
diagnosis is autoimmune hemolytic anemia. Okay, second,
it could be an acute glomerulonephritis. But we can't confirm it because she just had past cola-colored urine. We don't know whether it is hematuria or hemoglobinuria or myoglobinuria. But from history, it could be acute glomerulonephritis, or it could be some intravascular hemolysis due to malaria, or it could be a plastic crisis by parvovirus. Ma'am, hello?
you can consider HUS, no? Hemolytic uremic syndrome as a differential.
Yes.
Hemolytic uremic syndrome. Next, you told about crisis. What crisis?
A plastic crisis
Mm,
by
uh,
parvovirus.
hemolytic crisis, no? Hemolytic crisis.
Okay.
How do you differentiate clinically hemolytic crisis from aplastic crisis? Clinically,
Hemolytic,
both will cause sudden drop in the hemoglobin and severe pallor. But clinically, how do you differentiate between
plastic
aplastic
crisis,
crisis
there
and
won't be any
hemolytic?
bleeding manifestations.
Hmm?
I mean, there is no thrombocytopenia. The WBC count and platelets are normal. So,
Increase in the jaundice, no?
yeah.
Increase in jaundice in hemolytic crisis. But that is not seen in aplastic crisis. Sometimes it may be reduced. That is a main symptom which will tell you that it is hemolytic crisis. On examination, you will find spleen enlarging in hemolytic crisis. So, appearance of jaundice, deepening of jaundice is a clue to hemolytic crisis rather than aplastic crisis. Okay. So, you told autoimmune hemolytic anemia. 2 will consider HUS. Then you told crisis in
A plastic.
hemolytic anemia. Then you told malaria. Then
Glomerulonephritis, acute glomerulonephritis, ma'am.
why severe anemia? The mother has noticed severe pallor. No?
Only that is the thing. And
Drug-induced hemolytic anemia.
yeah.
Drug-induced hemolytic anemia. Then can this be G6PD deficiency? Because there is an infection,
so it's
the
most
child was
commonly
on
seen
some
in.
drugs. Can this be G6PD deficiency?
No, ma'am, because it is an X-linked recessive disorder. So it's most commonly
Yeah.
seen.
This is a girl child. So
Then
very rare to have.
there is also possibility of hello, ma'am. Can you hear me? Leukemia, but there is no bony tenderness or generalized lymphadenopathy as such. But an ALL can also not be ruled out.
Because of the sudden onset of pallor. In between, you told there was a low platelet count, no?
Yeah, initially they went to a local hospital from where the blood investigation done showed 1.45 lakh platelets. So, but rest of the parameters were normal. But later on, after 2 days, they rechecked it again. It was normal, and there was a sudden drop in hemoglobin.
So, how do you diagnose hemolytic uremic syndrome?
It is microangiopathic hemolytic anemia, then chronic renal failure, and thrombocytopenia.
Is it chronic?
No, acute renal failure, thrombocytopenia, and microangiopathic.
Microangiopathic hemolytic anemia, as evidenced by hemoglobin
Hemoglobin
less than 10, Then,
Thrombocytopenia.
other criteria, tell it as HUS, ISPN guidelines, ISPN guidelines.
Ma'am, I didn't understand. I didn't get you, ma'am.
ISPN guidelines for diagnosis of HUS. Okay, microangiopathic hemolytic anemia, hemoglobin less than 10. What else? What else?
Thrombocytopenia.
Schistocytes more than or equal to 2%. Then elevated LDH more than 450 and undetectable haptoglobin. Second criteria, all these criteria are required. Second is thrombocytopenia. The cutoff is less than 1.5 lakh. You told it was 1.4 something. That's why I'm telling. Okay, third is AKI. AKI, rise in creatinine by 50% over baseline. So these are the three criteria to diagnose HUS. This is the ISPN guidelines. Okay. So you have told thrombocytopenia, and that's why I asked about HUS. Okay. Any other differential? So, okay, with this differential, we'll go into the exam. We'll continue.
Family history. She's the second child of non-consanguineous married couple. There's no history of similar illness in the family, no history of gallstones or bleeding tendencies or splenectomy in family members, and no history of jaundice in family members.
Okay, you have to ask about history of immunodeficiency or autoimmune diseases in the family. No? Why is it important? It is important in prognosis. No?
Okay.
In the treatment part, it is given a family history of immunodeficiency or autoimmune disease is a bad prognostic factor in worm.
Yes, yes.
You have to ask for history of autoimmune disorders and immunodeficiency because it will affect the prognosis.
Okay. Coming on to antenatal history. First trimester, age of mother at the time of conception, 30 years. Pregnancy was confirmed by UPT after 2 weeks of missing her periods. It was a booked case and there was hyperemesis for the mother. Folic acid tablets were taken. No history of fever with rash, diabetes or hypertension or thyroid diseases in mother. No history of radiation exposure. No history of anemia. And no history of bleeding PV or threatened abortion.
Tasni, what are the other causes of discoloration of urine?
Ma'am,
You told hemoglobinuria, hematuria, myoglobinuria.
Yeah, either it could be drug-induced, like anti-malarials, quinine, quinidine, ampicillin, ceftriax. Hello, ma'am?
That is again hemoglobinuria, no?
Or
that
food, ma'am. Certain food, like beetroot, blackberry additives.
Okay.
Then it could be due to some metabolites.
Like?
In alkaptonuria, homogenetic acid.
Homogenetic acid and alkaptonuria. What is alkaptonuria actually?
Actually, this one is like it's a metabolic disorder, ma'am.
Okay. Tyrosine metabolism.
Tyrosine.
So it is due to the color is due to homogenetic acid.
Black.
Other than that,
ma'am, drugs like rifampin, nitrofurantoin.
Okay. Porphyria.
Yeah, porphyria.
What is the color due to? What is the metabolic which gives color to urine?
Delta.
Delta aminolevulonic acid. And porphobilinogen. This porphobilinogen is the main thing. This gets converted to porphobilin, which imparts the port wine color, purplish color to urine. But it's very rare, no?
Yeah.
Which is the commonest porphyria in a pediatric age group?
Commonest porphyria.
In the pediatric age group is erythropoietic protoporphyria. Erythropoietic protoporphyria is the commonest porphyria in the pediatric age group worldwide. And in adults are also included. It is the porphyria cutanea tarda. So erythropoietic protoporphyria usually will not result in urine discoloration. Urine discoloration is not usually seen. But congenital erythropoietic porphyria, which occurs in infancy, can impart this color to urine. It's a very severe disease. And it is the rarest one, least common one, but there will be urine discoloration. Okay, the most common one usually will not result in any urine discoloration. That is the point here. And when the child passes urine, will there be any discoloration?
Ma'am, in porphyria?
Yeah, in porphyria, when the child passes urine, will there be any discoloration?
No, ma'am.
Usually not. Usually there will not be any discoloration while passing the urine immediately. It will take some time, some hours or some days for the urine to change the color. Okay. Some discoloration can be there immediately, but the typical color will take some hours to days to develop. Okay. Can there be anemia in porphyria? There can be severe anemia. Okay, you can continue now.
Second trimester. Quickening was felt at 5th month of pregnancy. 2 doses of TD was taken. Iron, calcium supplementation was taken. There was no history of fever with rash, hypertension, no history of gestational diabetes or decreased fetal movements. Anomaly scan was normal and there is no history of transfusion. Third trimester, no history of fever with rash, antepartum hemorrhage, no history of decreased fetal movements, and no history of drug intake. Then shall I proceed?
Proceed.
Natal and postnatal history. Born at term by LSES, previous LSES, cried immediately after birth, birth weight of 2.9 kg, normal transition, no blood group incompatibility, no history of neonatal hyperbilirubinemia or neonatal bleeding. Breastfeeding was initiated soon after delivery, exclusively breastfed up to 6 months of age, followed by weaning. Developmental weaning.
Show the complementary feeding, no? Weaning is not used, the term is not used, no? Okay. Followed by complementary feeding.
Developmental history. Gross motor, she's able to walk, run and jump. Fine motor, able to write and draw pictures. Language, she speaks fluently. Social, plays with the peers. Currently studying in 3rd standard with good scholastic performance.
Tasni, gross motor, able to walk, run, jump. Walking is at what age, Tasni?
Ma'am,
running.
13 months, ma'am.
This child is 8 years old, no? So what you should be asking in gross motor? Better if you ask for bicycle riding. Bicycle. This is an 8-year-old child, no? So 3 years, tricycle. 3 to 5 years, bicycle with side wheels. After that, bicycles. From 6 years to 12 years, you can ask about bicycles. Only thing is the size will differ. The size of the wheel will differ. So for a 8-year-old, and it will depend on the experience also. So for an 8-year-old child, the ideal wheel size is 20, 60 into 20. That is what you have to ask. Will the child ride a bicycle? So because running, walking and jumping, that's for a smaller child, no? Okay, so for an 8-year-old child, better if you ask about riding bicycles.
Okay, ma'am.
20-inch wheel, but 16 to 20 inch. Again, that will depend on the experience, exposure. Fine motor, able to write and draw pictures. Which picture you will make the child draw? 8 years, no?
Yeah.
Double-lined cross.
Double.
So you have to make the child draw a double-lined cross. And what is the 9 years? If the child is
Cube, ma'am.
cube is at what age? 11. No, 9-year-old will draw a cylinder. Okay. Language, speaks fluently, social plays with peers. Good scholastic performance. Okay, continue.
Immunization history. Immunized according to National Immunization Schedule. BCG scar present on left upper arm, and there was no adverse events were noted following immunization.
Okay.
This is her dietary history. Expected calories 1,600 kilocalorie and expected protein is 25 gram. This was a dietary history which was taken during a pre-illness time, and her energy calorie was 1,340 kilocalorie and protein of 56 gram protein. She basically eats a lot of fish, so her protein is above the expected one. But she's a picky eater and she doesn't include vegetables in her diet. So there's a calorie deficit of around approximately 16 to 25% with adequate or high protein. Socioeconomic history. Lives in a Paka house with 3-bedroom attached bathroom, water from well near home and uses after boiling, segregated waste collection, well-ventilated house. There's no usage of wood for cooking, education of father 10th standard, education of mother 12th standard, occupation of mother housewife, occupation of father is a goods driver, income 25,000 per month, belongs to lower middle class family according to modified Kupusami classification. This is a summary, ma'am.
Yeah.
SF, an 8-year-old previously healthy girl born out of a non-consanguineous married couple, presented with fever for 10 days duration, started as low grade, later became high grade with chills and rigors, with bilateral painless cervical swelling, right more than left, progressive EC fatigability, dark collar-colored urine noticed since day 6 of illness, progressive pallor and exertional palpitations. Initial evaluation showed transient thrombocytopenia followed by a rapid fall in hemoglobin with no history of bleeding, abdominal pain, edema, or prior transfusions. Immunized as per National Immunization Schedule, normal growth and development, adequate protein but calorie deficit diet, and middle class background with good sanitation.
Okay.
Shall I proceed?
Diagnosis after this.
Ma'am?
You have written a differential diagnosis after this?
Yes, ma'am.
And the mother has not noticed any yellow discoloration of the eyes, no? Mother has not noticed.
No, mother did not notice.
Acute glomerulonephritis with gross hematuria, secondary anemia, severe anemia, so much severe anemia, unlikely. No? Okay, we'll consider that. Hemoglobinopathy with aplastic crisis, hemolytic crisis. That also should be included. Okay. We have not included G6PD because this is a girl child. Okay, we'll proceed.
Moving on to the examination part. Child was ill looking, very pale and dyspneic. She was conscious and oriented, well nourished, with IV cannula on left hand. Vitals, temperature 100.8 degree Fahrenheit at right axilla, respiratory rate 40 per minute, abdominothoracic regular, saturation 99% on nasal cannula, oxygen 2 liter per minute, BP 90-60, right arm in lying down position, heart rate 142 per minute, regular rhythm, high volume pulse, normal in character, no radial or radiofemoral delay. All pulses were bilaterally palpable and equal. Capillary refill time, filling time less than 2 seconds. Head to toe examination, no dysmorphic facies, head shape normal, eyes conjunctival pallor and icterus present, no subconjunctival hemorrhage, oral cavity carries tooth present, no angular stomatitis or glossitis, neck, bilateral cervical lymph nodes are enlarged, largest measuring 1.5 into 2 centimeter. Right posterior triangle, at right posterior triangle of neck, mobile, non-tender.
Level 5. Posterior triangle means level 5.
Yes.
What are Virchow's notes?
Uh,
Virchow's notes. Left supraclavicular nodes.
left supraclavicular.
Virchow's nodes. And what do you call the enlargement? What is a sign? Troisier sign. Virchow's nodes. Enlargement you call as Troisier sign.
Okay.
You get it? Sometimes that may be the only node which is enlarged in malignancies of the stomach, of the pelvis, pelvic region. Virchow's nodes are in level 4. Okay. Bilateral cervical nodes, 1.5 to 2 centimeter over the right posterior triangle of neck. Okay. Left side.
Ma'am?
Left side. It was a smaller node.
Yes.
Okay. Axillary was there. Axillary, inguinal, epitrochlear.
No, ma'am. No, ma'am. Only cervical lymph nodes was there.
Yeah. Others were not enlarged.
No, no, ma'am.
Okay, can continue.
Generalized jaundice was present. Nail, no
Where all
clubbing.
will you look for icterus?
Ma'am,
Where all will you look for icterus?
we look at the sclera,
Mm.
then palms, ma'am,
Mm.
then palate
Ah.
of
Under surface of tongue.
under surface of
Mm. Generalized jaundice. Yes. How much was the bilirubin?
her bilirubin was 7 point direct bilirubin.
Total bilirubin
Total
was
bilirubin was 7.4.
7. You just tell icterus is present. Generalized means like a newborn. No? For newborn, we tell according to levels, zones. No? So you just tell icterus is present. Okay, continue.
Nail, no clubbing or koilonychia, no petechiae, purpura or other skin bleeding manifestations. Bonds and joints, no sternal bony tenderness, no joint deformities. Perianal region, no bleeding hematomas. Of
It's important.
ma'am,
Why purpura is important? Purpura.
ma'am, any thrombocytopenia or any leukemia?
Thrombocytopenia. It can be due to vasculitis, no? Okay. Vasculitis or thrombocytopenia. Sternal tenderness. Joint deformities. Joint deformities. Why did you mention that?
JIA, ma'am.
Okay. Why is it important? JIA.
Sometimes chronic illnesses can also cause this anemia, no? So
Secondary.
secondary. This is the anthropometry. Weight was 25.2 kg. height 129 centimeter, weight for age between 25th and 50th centile, height for age between 25th and 15th centile, and BMI was 15.14 kilogram per meter square between 25th and 50th centile. Moving on to systemic examination, gastrointestinal system, oral cavity, mucosa was
Examination, do you want to add on something or do you want to delete some diagnosis from your provisional differentials? You had differential diagnosis, no?
Ma'am,
After
acute
exam.
glomerular nephritis is unlikely because the BP was normal.
Right. There is icterus, no? So
Also, aplastic is also, this,
leukemia,
yeah, leukemia also.
leukemia less likely.
Systemic examination, gastrointestinal system, oral cavity, mucosa pale, dental caries present, no angular stomatitis or glossitis, tongue was moist, no atrophy, no active bleeding from gums. Inspection, abdomen flat and symmetrical, umbilicus central and inverted, no distensions, no visible peristalsis, no visible vein scars or sinuses seen. Palpation, superficial palpation, abdomen was soft, no guarding, no rigidity. Deep palpation, liver palpable 4 centimeter below the right costal margin. Smooth with soft, smooth with liver span 9 centimeter. Splenic tip palpable, firm, non-tender, moves with respiration.
So with these findings, okay, next. Okay.
Percussion, liver span 9 centimeter, upper border of liver percussed at 5th right intercostal space, no shifting dullness, no fluid thrill.
So with these findings, tell the differentials again.
There is mild hepatomegaly only, and there is no splenomegaly. So,
previous slide. Spleen tip is palpable, no? Spleen tip is palpable. So there is a splenomegaly.
okay.
So with this findings, now what do you want to consider? You already told differentials, no?
So it autoimmune hemolytic anemia is actually a possibility.
First diagnosis.
Yes.
Oh.
Then, ma'am, infections like malaria, ma'am. Then leukemia is unlikely because jaundice is there. Then what else?
Then anything else? Hemolytic anemia?
Yeah.
With crisis?
Yes.
What is the most common hemolytic anemia?
Most common is enzyme infection.
In this child, can this be thalassemia major? Can this be thalassemia major?
But there's no chronic anemia, and there's no, because it was sudden onset followed by
How
fever.
does thalassemia major present? How does thalassemia major present? What is the age at which thalassemia major presents?
After 6 months.
No,
6
in infancy. And it is a transfusion dependent anemia. So there is no transfusion dependence. So this cannot be thalassemia major. Right? Can this be hereditary serocytosis?
Yeah, but there's no history of spleen. This one.
Signs that may be missed. Mild distress may not be very evident. Okay. Sometimes crisis will be the first time when they present to the hospital. There are many case reports where hereditary spherocytosis has presented in crisis in adult life, in the 20s and 30s. Okay. So anyway, your first diagnosis, autoimmune hemolytic anemia. The child was on some drugs, right? Which
Yeah.
are the drugs cause hemolytic anemia?
Actually, they use ceftriaxone, ma'am, 2 days. So that can cause hemolysis.
What is the mechanism of drug-induced hemolysis?
It is not
What
oxidative.
are the mechanisms of drug-induced hemolysis?
Oxidative in G6PD. Oxidative.
Oxidative damage in G6PD deficiency. Okay. What actually happens in G6PD deficiency?
Because the RBCs, they are in an oxidative stress due to they won't be reduced glutathione. So when the glucose 6-phosphate dehydrogenase is deficient, so that causes the RBCs to be in a oxidative stressful state. So that causes this hemolysis. Reduced glutathione is absent.
What is the function of G6PD?
It converts this
Glucose 6-phosphate to 6-phosphate
converts
gluconic acid. In this reaction, NADPH is liberated. This keeps the glutathione in the reduced state, GSH. So if this is not there, what will happen? The SH group will get oxidized during stress, any infections or a drug intake. So that will result in oxidant damage. So that is a problem. Okay.
auscultation.
So when you told G6PD deficiency, what are the other mechanisms by which drug causes hemolytic anemia, drug-induced hemolysis? What are the mechanisms?
It can be in
Hapten type, ternary complex, then autoantibodies. These are the three mechanisms given in Nelson. Okay. Hapten type means the drug binds to the RBC.
EC.
Then an IgG antibody forms a complex and this is destroyed. This is Hapten type. Second is ternary complex where the drug will not bind to the RBC. It will bind to the antibody which will recognize the drug and the RBC. It will just form a ternary complex. That is the second mechanism. Third is antibodies are formed. Third mechanism is antibodies are formed against the drug.
Immune complex.
Can you tell some examples? For Hapten mechanism?
Penicillin, ma'am.
Penicillins and cephalosporins. We have already used cephalosporins, no? So penicillins and cephalosporins act through drug-dependent Hapten mechanism. Second is ternary complex. Example is quinine, quinidine. Quinine, quinidine. Hydrocortisone also is given in that. Then antibody form.
This methyl
dopa, which is the drug said to be causing the most cases of hemolytic anemia. As per Nelson, it is cephalosporins. Cephalosporins are the ones because in all the three classes, cephalosporins are given in Nelson. So Nelson mentions cephalosporins are the most common cause of drug-induced hemolysis. But up-to-date mentions it is piperacillin. Piperacillin is the commonest drug causing hemolytic anemia. Okay.
Respiratory system examination. Examination of upper respiratory tract. Nose, no deviated septum or polyp. No nasal congestion or discharge or rhinorrhea. No bleeding of foreign body. No flaring of nasalae. Air sinuses, no frontal, maxillary or ethmoid tenderness. Throat, no cleft palate, postnasal drip, no pharyngitis. Tonsils not enlarged or congested. lower respiratory tract. Inspection, thoracic type of respiration, respiratory effort, no intercostal, subcostal, suprasternal retraction seen, shape of chest symmetrical, movement of chest wall symmetrical, apical impulse not seen, no kyphosis or scoliosis. Palpation, trachea central, chest expansion equal bilaterally, vocal fremitus is normal and equal on both sides. Percussion, resonant note all over the lung fields, no areas of dullness or hyperresonance. Auscultation, normal vesicular breath sounds present, air entry bilaterally equal, no added sounds. Cardiovascular system. Inspection, precordium appears normal, no visible precordial bulge, no visible pulsations. Palpation, apical impulse felt in left fifth intercostal space, just medial to midclavicular line, no palpable thrill. Auscultation, S1, S2 present, a systolic murmur heard, soft blowing, heard best at the left upper sternal border, which was non-radiating. CNS examination, higher mental functions, child was conscious, oriented to time, place, and person, speech normal and appropriate for age. Cranial nerve examination, all cranial nerves intact, pupils bilaterally equal and reacting to light, no facial asymmetry, extraocular movements are normal. Motor system examination, bulk normal in all four limbs, no wasting, no fasciculations. Tone normal in all four limbs, power 5 on 5 in all four limbs. Reflexes, both deep tendon and superficial reflexes present. And sensory system, touch, pain, and temperature was intact. No cerebellar signs and gait was normal.
Okay, tell the summary.
An 8-year-old girl child born out of a non-consanguineous married couple, developmentally normal and immunized up to age, presented with fever, swelling over the right side of
The
neck.
examination, you can tell it is lymphadenopathy.
Okay, ma'am.
Recovery is the end. So after history, you can say swelling. So at the end, you should be mentioning about fever, cervical lymphadenopathy. Okay.
Cervical lymphadenopathy. EC fatigability of 10 days duration, dark collar-colored urine, and progressive pallor for 3 days, and palpitation for 3 days. Her diet was deficient in calories with high protein. She predominantly avoids vegetarian food. And on general examination, child has normal growth parameters, was sick looking, dyspneic at rest with severe pallor and jaundice. Systemic examination revealed mild hepatomegaly with a flow murmur in the pulmonary area. So,
Splenomegaly was also there, no? Very important finding, no?
ma'am?
Splenomegaly was also there, no?
Okay, ma'am. Tip of,
Okay,
yeah.
This is also a very important finding. Okay.
So, these could be the differential diagnosis after my examination. Now, to confirm it, we may need to look after the investigations, complete blood count. But acute lymphoblastic leukemia can be ruled out.
I told about jaundice, generalized jaundice. Told. So rather than a crisis, it will be hemolytic crisis, which is more apt. Okay, ALL with jaundice, we'll see. So your first diagnosis is autoimmune hemolytic anemia. So how will you classify autoimmune hemolytic anemia?
We have warm autoimmune hemolytic anemia and cold autoimmune hemolytic anemia. Warm is an IgG antibody mediated hemolysis. And it is most commonly seen in
Can again classify it into primary and secondary.
okay, ma'am.
Primary and secondary.
Secondary due to SLE, autoimmune diseases, SLE.
Like SLE.
Then CLL.
Autoimmune disease.
Rheumatoid arthritis, ma'am.
JIA. Okay. Then, okay, when you tell JIA, you can tell dermatomyositis.
Okay.
Autoimmune hepatitis, type 1 diabetes, autoimmune thyroiditis, Sjogren's. So many conditions are given, no? In Nelson also is given. In UpToDate also is given. Then ALPS. What is ALPS?
As autoimmune
lymphoproliferative syndrome. What is Evans syndrome?
Evans syndrome is a condition where you see autoimmune hemolytic anemia plus ITP.
So purpura is important. I had asked no that thrombocytopenia, and so if a child has two cytopenias, it's very important. Why is it very important? Again, the prognosis, no.
Okay.
Prognosis of autoimmune hemolytic anemia is better than Evans. Evans, it runs a chronic course, chronic course with relapses. So the treatment is difficult. Prognosis is compared to autoimmune hemolytic anemia. Prognosis is not that good, no? So cytopenia in 2 lines is very important. Okay. What are the symptoms of ALPS? I have only seen one case in my life. Again, chronic lymphadenopathy, hepatomegaly, splenomegaly. The child also can have cytopenias, autoimmune hemolytic anemia, thrombocytopenia, then neutropenia. As a result of this neutropenia, severe infections can occur. So chronic lymphadenopathy with organomegaly and cytopenias. That is the clinical picture in ALPS. Why I am telling about ALPS is Evans syndrome. 50% of children with Evans syndrome will be having ALPS. So if there is a drop in the platelet count, you have to consider ALPS. Once you told there was a low platelet. So that's why I'm telling. If a child with autoimmune hemolytic anemia has an associated thrombocytopenia, you should be looking for Evans syndrome. Evans is responsible for about 15 to 30% of cases of pediatric AIH, autoimmune hemolytic anemia, 15 to 30%. And half of the cases are due to ALPS. So symptoms I have already told. What is said to be the hallmark of ALPS? What investigation? I thought you have done that. Oh. DNTs. Have you heard of DNTs?
No, ma'am.
DNTs, double negative T cells. That is the hallmark of ALPS. This child which we had referred to RCC suspecting leukemia, the diagnosis came as ALPS, and it was written as DNTs positive. DNT is, what are DNTs?
Double nucleus.
DNTs are double negative T cells. Double negative means CD4 and CD8 negative. That is the hallmark of ALPS. So actually, I was seeing that case for the first time, ALPS and DNTs positive. Then that time I referred, and then only I knew about this diagnosis. Okay, that's long back. Only a single case of ALPS I have seen. It was after flow cytometry, the diagnosis they had put as ALPS because of DNTs, double negative T cells, CD4 and CD8 negative cells. So children with ALPS can have other autoimmune problems like autoimmune hepatitis, autoimmune hepatitis, glomerulonephritis, vasculitis, all autoimmune problems they can have. This we should know because if there is thrombocytopenia, we'll put the diagnosis as Evans, but it may be a case of ALPS. Okay. Continue with the classification. You were telling about warm AIHA.
And cold.
Warm AIHA also primary and secondary are there. Cold also primary is there. Secondary is there.
Secondary.
Infection.
Cold primary and secondary is there. Secondary due to Epstein-Barr virus, CMV, Mycoplasma pneumonia.
Okay.
Then it is basically due to the
Cold hemoglobin.
complement
What is
mediated.
PCH?
Ma'am,
What is PCH?
paroxysmal cold hemoglobinuria, where you get see biphasic antibody.
You can put a differential as PCH, no? For this child, you can put a differential as PCH.
Where the
okay.
Donat Landsteiner antibody.
What are they?
biphasic antibody where the antibody binds to the RBCs in cold temperature and cause lysis at warm temperature. DCT is positive.
Okay.
That's what I know.
So, how is the prognosis of PCH?
It is actually good.
Actually good. Many will have only one episode. It's a childhood disease. Many will have only one disease, one episode. So you can put here PCH as a differential diagnosis. HUS and paroxysmal cold hemoglobinuria also you can put as a differential diagnosis. Can you tell the classification again? Warm primary is the
Primary and secondary is there. Cold, primary and secondary.
Secondary to
Cold one, secondary due to Epstein-Barr virus, cytomegalovirus, mycoplasma, pneumonia.
Okay, what percentage of IMN will have lymphadenopathy? Because the child had fever and lymphadenopathy, cervical lymphadenopathy, no? What
Yes.
percentage of children with IMN will have lymphadenopathy? 90%. What percentage of children with IMN will have splenomegaly? 50%. What percentage of children with IMN will have hepatomegaly? 10%.
Okay, ma'am.
These are the figures in Nelson. So different books will give different values, but you can quote the figures in Nelson. That's always accepted.
Okay, ma'am.
So you can put PCH also, PCH and HUS also. Okay, you are going with investigations now?
Shall I go, ma'am? Time.
Okay.
So,
what was the next slide? Proceed
how to
as you are
evaluate
prepared.
how to evaluate
How
it.
to evaluate. Okay.
We do the complete blood count with reticulocyte count and peripheral smear. It is
Tell
based.
all the findings you will expect. Full
Yeah.
blood count means hemoglobin. You will
We
definitely
look for
look for
hemoglobin. We look for the indices,
look for a low hemoglobin level. Like that, you tell all parameters and the finding which you will look for.
Yeah.
Total count.
In complete blood count, we look for three cell lines. That is RBC series, WBC, and platelets.
Okay.
RBC series, we look for hemoglobin to be low in hemolytic anemia. Then the indices, MCV, MCH, and MCHC. MCV is actually the size of RBC.
Okay.
And MCH is the amount of hemoglobin, the content of hemoglobin in RBC. And then,
so what will happen to these?
ma'am?
What will happen to MCV and MCHC?
It is normocytic, normochromic in hemolytic anemia, ma'am.
So if you are analyzing blood with the analyzer,
if there is reticulocytosis, we can see macrocytosis.
Of 125. Your investigation, I had seen one report as 120 or something.
Yeah.
Correct, no?
Yeah, so that is MCV is more. So it is
what is the
macrocyte.
reason?
Macrocyte. Ma'am?
What is the reason for that?
Because as the bloods get lysed in the blood vessels, the bone marrow produces reticulocytes. So reticulocytes are actually larger in size than compared to the normal RBCs. So that is a reason for high MCV.
Any other reason? There is clumping, no?
Yes.
So that result in a spuriously high value. So RBCs will not be passing one by one if there is clumping, especially in cold CAD, cold agglutinin disease. RBC will be passing in clumps, though that can result in a spuriously high value. So MCV can be elevated because of that RBC clumping. MCHC, what will happen? In warm hemolytic anemia, what will happen? Warm AIHA, what will happen to MCHC?
Decreases, ma'am.
What will be the cells in
Ma'am.
what type of RBCs will be there in warm? What will happen to MCHC in hereditary spherocytosis?
Increase.
Increase,
The
no.
spherocytes increases.
It is increased. So in warm AIHA, you will find many spherocytes and microspherocytes. So MCHV may be elevated. Continue then. Told about hemoglobin. You told about RBC indices. What about RBC histogram? Or, what will you look for in RBC histogram? What are flags? You will be looking for
Flags.
flags are abnormal signals when the blood passes through the analyzer, when there is an abnormality in the blood. So you can get RU flags. RU flags means in the RBC histogram, you can get a flag in the upper discriminator, because of the clumping. Okay, large size RBCs. You can get a RU flag. So RU flag is due to, what is the cause of RU flag? What is meant by flag? Lower discriminator, upper discriminator, flag. What is lower discriminator or LD? So when platelets and RBCs, they are analyzed in a single chamber. So according to size, there will be different peaks. Those cells below 25 femtoliter will be counted as platelets. So RBCs will be of the size 55 to 125. So smaller ones will be platelets, larger ones will be RBCs. So if RBC clumps are there, what will happen? The size will increase, no? So up at the upper discriminator, you will get a flag. That is RU flag. You understood? If there are platelet clumps, what kind of flag we will get?
Under
Lower discriminator flag, no? LD flag. If there are platelet clumps, the size will be again less, near the 45 or 55. You will get a RL flag. Understood? Okay. So when you get flags like this, you will have to assess the peripheral smear and find out if there are any abnormalities. It is clear? Okay. Next,
then
what you will look for?
peripheral smear. We look
Total
for
count. Total count.
total count. Yes, ma'am. We have to look for the total count as well. So in
Why?
we'll have to rule out whether it is like in case of autoimmune hemolytic anemia or the other causes. Like it can be normal, increased, or decreased in leukemia. Can be it can be decreased in megaloblastic anemia as well. And then
Because there will be so many nucleated RBCs, total count may be
counted as total WBC count also sometimes.
So in associated bone marrow failure syndromes, the count can be low. Okay, what is the next thing you will like to look for?
Then we look for after the complete blood count peripheral smear, we'll have to look for direct antiglobulin test, Coombs test, ma'am.
Platelet count, very important, no?
Very important. Platelet count, we look for the size, the number, megakaryocytes, and the number of
Size, why do you look for?
Ma'am?
Size, why do you look for the size?
Actually, in immature platelet fraction, if the size are more, then it is like regeneration is more.
You are telling about the
Platelet.
IRF.
Then
Platelet.
then platelet, number of platelets, ma'am. If
There is associated thrombocytopenia, you'll be considering events, no? Autoimmune hemolytic anemia along with thrombocytopenia, you have to consider a diagnosis of events. Like we have discussed earlier, you have to consider autoimmune lymphoproliferative syndrome also. Any other? So thrombocytopenia can be there in other immunodeficiency conditions, no? Which immunodeficiency?
ITP.
CVID.
Yes. Bernard
CVID sometimes can present as ITP, no? So if the platelet count is less, you have to be more careful because you told about malignancy. It can be events, it can be CVID, other autoimmune conditions. Then MAHA, microangiopathic hemolytic anemia, where the platelet count is less. So that is the importance of platelet. If you're seeing a very low platelet count, that may be favoring a diagnosis of HUS. HUS criteria we have already discussed, no? What are the criteria?
Thrombocytopenia, acute renal failure, and microangiopathic hemolytic anemia.
Okay. As evidenced by hemoglobin of less than 10.
Less than 10. And then LDH more than 450.
Schistocytes more than or equal to 2%. LDH more than 450. Or undetectable haptoglobin. What is this haptoglobin?
Haptoglobin is actually a protein released by liver. It actually just binds with the hemoglobin. So
binds.
once the haptoglobin saturation means more, the amount of haptoglobin produced gets over with the binding of hemoglobin, it gets reduced.
Free hemoglobin will get eliminated in urine, causing hemoglobinuria. Okay. So you have told about hemoglobin total count, red ticks, platelet count, then
moving on to direct.
Okay, that. What will be the finding?
Direct
in warm, the finding in cold. Yeah, what will be the finding?
Yeah, it detects the presence of antibodies on RBCs. So if it is like IgG positive, it is warm autoimmune hemolytic anemia. And specific C3D, IgM antibody positive, it is cold autoimmune hemolytic anemia. Then we'll have to look for the
get what?
C3D,
what will you get?
Specific C3D positive.
Why you don't get C3b?
C3b, ma'am.
C3 convertase split C3 into C3b and C3d. No, both will bind to RBCs. Why you are not getting C3b? You are getting only C3d. No, why is it like that? While doing that, no, in the washing process, C3b will get lost during the washing process. Why you will not get IgM? Why you will not get IgM? Because antibody in cold CAD is IgM, no? You're not getting IgM in Coombs. Why you're not getting IgM? It will bind to RBC, but it eludes from the RBC in the warmer parts of the circulation. So you'll not get IgM. You will not get C3b. You'll get only C3d. You understood why you're getting only C3d? Because you are getting IgG in warm, you are detecting it. But in CAD, the antibody is IgM, but you are not detecting that. You are detecting only complement C3d. So here the patient's RBC is washed free of any adherent plasma protein and then reacted with polyspecific antiserum first. And if it is positive, with monospecific antiserum. That is prepared against IgG and a fragment of complement, that is C3d. So that is about direct Coombs test. How do you grade it? Grading
Grading of ma'am?
that positivity.
3+, 2+, and 1+, ma'am.
What is 3+? 0, 1+, 2+, 3+, and 4+. 0, it is negative. 1+, small clumps. And turbid reddish background. 2 is medium-sized clumps. 3 is larger clumps, several larger clumps of RBCs. 4+ is solid agglutination of red cells. So 0, 1+, 2+, 3+, and 4+. In your child, you got 3+, right? It was 3+. So several larger clumps of RBCs. That was the result. Okay, then continue.
Then we'll have to look for the hemolytic panel serum bilirubin, where it is the unconjugated bilirubin will be raised.
Sense of hemolysis. Okay, hemolysis
Then
panel.
then lactate dehydrogenase will be increased, and haptoglobulin will be decreased or absent.
Reduced.
Then we'll have to do the urine dipstick test and microscopy to look for any to assess whether it is hematuria or hemoglobinuria. And
How
then
you differentiate?
we'll just centrifuge it, and then we'll look in the
Urine dipstick positive, but microscopy will not show any RBCs. It is hemoglobinuria. How do you differentiate hemoglobinuria from myoglobinuria? By doing a haptoglobin. If you have the haptoglobin report, haptoglobin will be normal in myoglobinuria. Haptoglobin will be normal in myoglobinuria. Understood? If you have the result, you can differentiate, no?
Okay.
So if urine microscopy is negative and urine dipstick is positive for blood, it may be due to hemoglobinuria. It can also be due to myoglobinuria. But if the haptoglobin level, you have already done a haptoglobin level, if you have done it, a normal haptoglobin level is more in favor of myoglobinuria. Understood? Okay. Serum creatinine, electrolytes,
to assess
for renal function, there is hemoglobin. This child already had hemoglobinuria, already had hemoglobinuria.
And blood culture and infectious workup can also be done, whether it is caused due to dengue, where the parvovirus, malaria, then mycoplasma serology can also be done if not done. Then we can do a chest X-ray and ultrasound neck. Chest X-ray mainly to look for any mediastinal lymph nodes, cardiomegaly. Then ultrasound neck to look for any other lymph nodes, to know the number of lymph nodes, the depth of lymph nodes. In
which AIHA do you get hemoglobinuria more often?
Ma'am, in which age?
Autoimmune hemolytic anemia, you will get hemoglobinuria more often. Is it in the warm or the cold?
It's in the warm.
It's cold, no.
Intravascular hemolysis is cold, so cold.
Intravascular hemolysis in cold. Complement mediated, no?
Then bone marrow aspiration can also be done. Smear suggests any blasts or pancytopenia to look for leukemia. Then
what all will it the peripheral smear?
We look for ma'am any abnormal cells like schistocytes.
What are schistocytes?
They are actually lysed RBCs, which is seen in this AIHA.
Small number of schistocytes are seen in AIHA. Mainly schistocytes are seen in HUS, no? That is one of the diagnostic criteria. Actually, how do they look like? Is there any criteria to identify schistocyte?
Nuclear cytoplasmic ratio.
No. There is a criteria, ICSH criteria, that is International Council for Standardization of Hematology, 2021 update, that is ICSH criteria. The schistocytes, you can include cells which are helmet cells, triangular shaped cells, and crescent shaped cells. These three cells are included as schistocytes. Understood. Okay.
But additional tests like G6PD assay can be done but for this case, since it is a girl child, need not do that.
And if you do it now, what will be your comment if you are asked to do a G6PD level now? This is a girl child. Okay. If it's a boy,
we can do, but yeah.
Lot of reticulocytes, no? Young RBCs, they'll have a higher amount of G6PD. So
And by
if you
itself,
do it now, sometimes the level will be near normal or normal. So you'll have to do it after a few weeks only. So if you suspect G6PD in any patient, you'll postpone the investigation for a few weeks because young RBCs, reticulocytes, will contain more of G6PD, and the old ones will have less amount of G6PD. So you'll postpone the investigation by a few weeks if you are seriously suspecting G6PD. Okay.
Then finally, hemoglobin electrophoresis if you're suspecting any hemoglobinopathy like thalassemia. But in this case, it is not recommended.
You will get many spherocytes in autoimmune hemolytic anemia, no? So hereditary spherocytosis will be a differential smear. You'll get microspherocytes and spherocytes. Where all can you get spherocytes apart from hereditary spherocytosis and autoimmune hemolytic anemia? What are the other conditions where you can get spherocytes? Burns, clostridial infection, snake bite, especially viper bite and all can get. Wilson's disease, can you get spherocyte? Is there hemolysis in Wilson's disease? Hemolysis can occur in Wilson's disease because of the toxic effect of free copper. So there also you can get spherocytes. Apart from AIHA and hereditary spherocytosis, you can get spherocytosis in some other conditions also. Okay. What are the other enzymopathies you know of? Apart from G6PD, what are the other enzymopathies?
Pyruvate kinase deficiency.
Pyruvate kinase, very good. Pyruvate kinase. That.
Enzyme, then
What is the role of pyruvate kinase? It converts phosphoenol pyruvate to pyruvate. Here also you can get aplastic crisis. In this also you can get aplastic crisis. What are the other enzymes, glycolytic enzymes involved other than pyruvate kinase?
So kinase.
Hexokinase. Hexokinase. Then phosphofructokinase. Phosphofructokinase. This is one condition where you get myoglobinuria. Phosphofructokinase, where have you heard?
Phosphofructokinase.
GST type 7, no? Glycogen storage disorder, type 7. So this can be associated with myoglobinuria, muscle cramps, that second wind phenomena. So you can get hemolysis and myoglobinuria in
Phosphofructokinase
phosphofructokinase deficiency. Then you can tell about aldolase. Aldolase, glucose phosphate isomerase. These are the enzymes. Nelson gives all this description of all the enzymes of glycolytic pathway. Okay. Okay. Continue. 9 now. Continue.
So this was the course in our hospital, ma'am. She was admitted in pediatric intensive care unit. Her blood investigations done showed normal total counts with predominant lymphocytes and low hemoglobin. Her vitamin B12 and folic acid levels were normal. Her hemolytic workup done showed elevated LDH and with positive direct home test C3D positive. Her peripheral smear was suggestive of
That confirms the diagnosis of
autoimmune hemolytic anemia.
cold agglutinin disease, CAD or cold agglutinin disease.
Her EBV IgM was positive and her IgM scrub type was lepto IgM and parvo were
What
negative.
IgM? What IgM? EBV
Epstein-Barr virus IgM.
Against which antigen? EBV IgM VCA, viral capsid antigen. That's most often done, no? Maybe viral capsid VC IgM VCA. Written only IgM left. VCA, maybe VCA.
Viral capsid antigen. HB electrophoresis showed no thalassemia or abnormal hemoglobin. She was transfused with least incompatible blood since her blood was not getting cross-matched with any of the bloods. She was initially transfused with 5 ml per kg PRBC and the next day with 10 ml per kg. Post-transfusion, her events were uneventful. She received injection methylprednisolone pulse dose for 3 days and was started with steroids 1 mg per kg per day. Her urine color, tiredness, and oral intake were gradually improved, and her repeat blood investigation also showed improvement. She was hence discharged with stable whitish with advice to continue steroids with a tapering dose for a total of 14 days.
How do you treat AIHA?
AIHA warm
cold,
auto
how do you?
Cold is actually supportive, ma'am.
Supportive.
We
You
don't
not need
give
steroid as per textbook. But when the child comes, we won't be knowing whether it is cold or warm, no?
in basically in
That
warm
needs
autoimmune
very
hemolytic
specific
anemia.
that, no? So, okay, you are planning to taper it and stop in 14 days. That's good. Okay, then
That's it, ma'am.
how do you decide on treatment in a case of CAD, cold agglutinin decide? How do you decide on treatment?
If that's basically supportive treatment, ma'am.
Basically supportive. You will treat if
Symptoms. Like if the child is very sick and hemoglobin level is less than 6 and she's hemodynamically unstable, we can give a blood transfusion.
Okay.
Then basically it is
There
self-limiting.
is symptomatic anemia, symptomatic fatigue, bothersome cold-induced circulatory problems, that is acrocyanosis. Then what you will do? If there is fulminant hemolysis, you can start with
Steroid.
not steroid. You'll start with something else.
IVH.
No. IVH. No, not IVH. The ideal drug which is mentioned is
Cold, ma'am.
for cold. Can give B cell directed therapy, no? B cell directed therapy.
B cell directed.
Sutimlimab is the one which is mentioned for severe fulminant hemolysis. That targets C1s protein to inhibit the classical complement pathway. So if this is not available, plasmapheresis, eculizumab is another alternative. If there is severe hemolysis, fulminant hemolysis, severe hemolysis requiring immediate action, you can give that. That is what is mentioned in UpToDate. Or you can use B cell directed therapy. What is ideal drug mentioned?
Rituximab.
Rituximab. Okay. So that is about cold. It's mainly supportive. If required, you can give these. And for warm, it is the first line is
Steroids, prednisolone.
there you will not wait because the cold AIHA can have a chronic course with relapses. So it is not supportive. You'll have to start pharmacotherapy for warm. So for cold, it is mainly supportive. If required, you can give this. But for warm, it is not supportive because there are chances for chronicity and relapses. You will straight away start with glucocorticoids. Okay. Then what glucocorticoid? How long will you give? That again will depend on the severity. If the hemoglobin is less than 7, you will give IV. If the hemoglobin is more than 7 to 8, you will directly start on oral prednisolone. So, treatment whether to give IV or oral will depend on the initial hemoglobin. If it is very less than 6 to 7, you will directly go with methylprednisolone. If it is more than 7 to 8, you can directly start on oral prednisolone. Okay, how long you will give?
4 to 6 weeks.
Methylprednisolone,
3
how
doses.
much will you?
Pulse dose for 3 days, ma'am.
Severe cases, you will give pulse dose for 3 days. Otherwise, the dose mentioned in up to date is methylprednisolone 0.5 to 1 mg per kg, 6 to 8 hourly for 24 to 72 hours. After that, you taper to oral prednisolone. So after that, you will consider it as a milder variety because most of the cases will respond to steroids within this time. But how long will you continue? If it is oral,
Oral prednisolone for 4 to 6 weeks, ma'am.
7. If the hemoglobin is above 7, you will give oral prednisolone. You will start with how much?
1 mg per kg.
2 mg per kg. Nelson says 1 mg. Up to date says 2 mg. 2 mg per kg. Then, how long you will give?
4 to 6 weeks.
Okay. It's mentioned as 2 to 3 months. Over that, you will have to taper to less than 1 mg per kg. So if you're not able to taper to less than 1 mg per kg over 3 months, what will you do?
We'll switch over to the
Second line drug. What is the second line drug? First line is always glucocorticoids. Second line is rituximab. Second line is rituximab. Then splenectomy. Third line is IVIG and this all other drugs, azathioprine, cyclosporin, tacrolimus. They give a list of drugs as third line. So first line is glucocorticoids. Second line is rituximab and splenectomy. So you'll always consider rituximab first as a second line drug. So when will you add rituximab?
when they're
If you're
not
not able to bring down the steroid to less than 1 mg per kg over 2 to 3 months, you will start the second line drug. Okay. So because this is a, okay, continue. It's already 9. Continue.
Actually, these are the blood investigations which we did from our hospital.
Can you interpret the reports fast?
28, ma'am.
Tell.
Yeah, 28th of January, it was 4.1 and it gradually decreased. And then after the blood transfusion, it increased.
Okay, good.
Third child was discharged.
Okay.
And then rest all were the investigations, man. Iron, it was high actually, 28th. When at the time of admission, the serum iron was on higher side, 231.
What is there to support your diagnosis in this slide?
It is not
LDH. LDH is there.
LDH is
Yeah. LDH above 450. Okay.
And
This
this
slide, what is there to support your diagnosis? Anything is there?
ma'am, next one it is
The diagnosis of hemolytic anemia, autoimmune hemolytic anemia. 2 criteria, അല്ലേ? എന്തൊക്കെയാ?
What, ma'am? Question മനസ്സിലായില്ല ma'am.
Evidence of hemolysis. Two
Ingredient-
is that possibility. Only these two are required to make a diagnosis.
Okay.
For warm, it is IgG. For
IgG.
cold,
For cold,
it is
just C3T positive.
only two criteria are required for making a diagnosis of
Autoimmune
autoimmune anemia. One is evidence of hemolysis.
hemolysis.
Two is positive DAT.
Positive.
The mere findings are supportive but not required for making a diagnosis. Okay.
These are the retic.
Previous slide bilirubin was more, no? Bilirubin was 2.7 and that. It was written as 2. Plus 7, it was 7 or 2?
2 point, ma'am.
2.0. Generalized jaundice nu parayanda. Because of the pallor, you might have felt. Okay.
Then the retic panel, ma'am.
What about liver enzymes? Go fast. Liver and
Initially ചെയ്തേ ഉള്ളൂ ma'am. 67 and 47.
in here, comment on the LFT.
The indirect bilirubin is obviously higher than the direct one. SUT
Okay.
it is mildly elevated.
Why? Can be elevated as part of hemolysis. No. SGPT will not be elevated. If SGPT is elevated, what will you consider?
SGPT.
Elevated SGPT in this child with autoimmune hemolytic anemia. What
is-
all will come to your mind?
Like in RBCs, it contains this AST, ma'am. So that can cause a release of SGPT.
SGPT will be normal in autoimmune hemolytic anemia. No, it will not be elevated. But if it is elevated, what will you consider? One, in IMN, elevated transaminases can be there in 75% of the cases. This is as per Nelson. Many books give 50% on. So as per Nelson, elevated transaminase without elevated bilirubin. Elevated transaminase is seen in 75% of the cases. So that can be due to that. Then what else? It can be autoimmune hemolytic anemia can be associated with autoimmune hepatitis. 3, we are telling about Wilson's disease.
Storage.
So in Wilson, hemolysis can precede liver manifestations or neurological problems. So if you are asked about hemolysis and elevated liver enzymes, you have to tell like this. In this case, it may be due to, if an elevation of SGPT is there, it may be part of the transaminase elevation in IMN. That is what you have to tell, because transaminases are elevated in 75% of the cases of IMN. Plus, you will also consider autoimmune hepatitis because it's an association. Okay. Can you interpret this?
Ma'am, this is the retic panel, ma'am. Initially, the reticulocyte percentage was 3.61 and gradually it increased. So the retic means it is actually compensating the lysis undergoing in our body. So it is like the reticulocytes is increasing.
What is this? I show the previous slide, because in our hospital, our analyzers will not give a report like this. So this is a very good slide. You have a very good analyzer. Is this the Sysmex automized analyzer?
Yes.
Sysmex ആണോ? അറിയത്തില്ല. Okay. What is this IRF?
Immature reticulocyte fraction.
Okay. How is it calculated? You add the MFR and HFR, you will get the IRF. See, 15 plus 33, it is 48, no? 22 plus 43, it is 65. So you have to add MFR and HFR to get the IRF. You had noticed that?
Yeah, no, I didn't notice, ma'am.
Okay. That means the marrow is producing lot of reticulocytes. This HFR has high RNA content. That HFR means reticulocytes with high RNA content. Okay, that is the active early regeneration. MFR means medium fluorescence ratio or middle fluorescence ratio. That shows active erythropoiesis. What is the normal value? Have any idea in your analyzer?
No, ma'am.
HFR normally is 0 to 1.5 in older children, 0 to 1.7. MFR is also about 1.5 to 11. That is the usual result of MFR. Here it is very much elevated. That shows the marrow is producing a lot of reticulocytes. And the low fluorescence ratio, LFR, that shows mature reticulocytes. That will be the remaining. You have to minus out from 100, no? So if you add everything together, you will get 100, right? If you add the high HFR, MFR, and low FR, you will get 100. If you add the MFR and HFR, you will get the IRF. Understood?
Okay.
So this shows there is active
Reticulocyte formation
erythropoiesis going on. So it is not a case of aplastic crisis. It is not a case of aplastic crisis. That is out. That diagnosis is out.
This was a PPINR, ferritin, and vitamin B12 and folic acid level. We initially did this because she was having high MCV. So to rule out megaloblastic, we did this, ma'am, but it was actually...
We explain no, why MCV is high because of the RBC clumping. Reticulocytes are big, but RBC clumping is the main reason for elevated MCV in analyzers. And we discussed about the flags, RU flag, no? RU flag and cold agglutinin. RU flag you get typically in cold agglutinin disease. Okay. This is the last slide.
I think so, ma'am.
DCT is positive, 3+.
Yeah.
We discussed what is 3+, right?
Yes.
Several large clumps. Antibody screening is positive. Antibody screening, why do you do? Find out allo antibodies. That may create problem with transfusion. Many of the transfusion reactions are due to allo antibodies. We have transfused the child. There can be antibodies which will interfere with
Transfusion reactions.
cross-matching. Okay. You should know the antigenic specificity of antibody. That is important. Malaria antigen test negative. Biovax and falciparum. What is the test you do for malaria?
Ma'am, we do the my rapid antigen test.
Rapid antigen. Which are the antigens?
This one. What is it?
HRP2. Rich protein 2 of falciparum and LDH and aldolase. These are the antigens, no? HRP2, LDH, aldolase. These are the antigens. What about thick smear, thin smear, rapid diagnostic test?
Look for the parasites and look for the species, ma'am. Malaria.
What is the sensitivity of thick film? What is the sensitivity of thin film? What is the sensitivity of rapid test? Thick film, it is 5 to 10 parasites. 5 to 10 parasites per microliter. It is 200 per microliter for thin smear. And for rapid diagnostic test?
Sensitivity.
How much? More sensitive or less sensitive?
Rapid diagnostic test is less sensitive.
Okay. Sometimes this falciparum HRP2 are doing for falciparum malaria, no? So
Yes.
some strains, some may be having deletion of the HRP2. So we'll get a false negative report.
Okay.
And this you will not be able to differentiate between new infection and effectively treated infection, because HRP2 that will remain positive for some weeks, even after treatment. For 1 to 5 weeks, that will remain positive. So always you will have to do a smear.
Okay.
Okay.
Leptospiral IgM antibody was negative. HP electrophorus already discussed, there was no evidence of thalassemia, and ANA by IF was also negative. Scrub typhus IgM was also negative. So basically, from the investigations,
ANA, indirect immunofluorescence, that is the gold standard for ANA. Rather than ELISA, immunofluorescence is the gold standard. Okay.
so from the basic investigations we did, a positive result was EBV IgM was positive, which indicates
We
active
have to mention as VCA.
and then
Antigen ഉണ്ട്, nuclear antigen ഉണ്ട്, EBV NA ഉണ്ട്, VCA ഉണ്ട്. So you have to mention it as IgM VCA. So it's an acute infection.
and basically from hematology, the LDH was markedly elevated, and direct home test was positive for C3D, so that clearly indicates it's a cold agglutinin disease, ma'am.
So in a warm AIHA, how will be the DAT?
IgG, ma'am. IgG positive.
Whereas C3D in cold
Uh,
will be it in PCH, paroxysmal cold hemoglobinuria.
Donat Landstein antibody, it's DCT is positive.
At 4 degrees Celsius.
Cold, ma'am, and 37 is warm.
PCH at 4 degrees Celsius.
Okay.
You told about the biphasic antibody, no?
Yes. So my final diagnosis, severe post-infectious complement-mediated autoimmune hemolytic anemia secondary to acute Epstein-Barr virus infection.
Severe post-infectious complement-mediated autoimmune hemolytic. You are telling it's complement-mediated because there was hemoglobinuria. Hemoglobinuria is mostly seen in CAD, cold agglutinin disease. But you can rarely get in warm also. In warm also you can get. If in some case of warm also you can get, if IgG is present in sufficient quantity and proximity to fixed complement, that can result in concomitant intravascular hemolysis.
Okay.
Will splenectomy do anything good in CAD?
No, ma'am, because intravascular. So cold agglutinin disease.
So there is no role for splenectomy also in cold. That is the importance of identifying whether it is warm or cold. Now we have completed a case of autoimmune hemolytic anemia. It's a rare case, right? Have you seen any, have you managed any IIT earlier?
Ma'am, actually we were getting 3-4 cases together, like recently, with same
same cases.
It was last, it was adenovirus positive.
Okay.
That's it.
Thank you, madam, for that wonderful discussion. Thank you, Tasni, for a good case presentation also. For some comments from Dr. Purushothaman, sir.
It is a very nice case, well discussed by Dr. Mary and Tasni. Tasni, in the initial history part, the hard findings were the acute onset of fast progressing pallor situation, urinary discoloration, and fever. The 90% of the cases, it's a recent onset pallor. There's a 10% possibility of a long duration pallor, now detected only is that one. And you keep that possibility in mind. The very interesting thing is in the combination urinary discoloration. You have discussed the urinary discoloration analysis very well. Madam was pointing out all the possibilities, whether it is a hematuria, whether it's other pigments, all the pigments you have considered, hemoglobin, myoglobin, metabolic porphyrin, alkaptonuria and all.
That analysis is very nice. There you need to consider first painful or painless. If it is painful, most likely it is RBCs only. In a painless situation, there can be RBC from the kidney or any of the other pigments. There, the point is, when was the urinary color? Urine color appeared later indicates alkaptonuria and porphyria. It won't be colored in the beginning. The other thing, it is colored, but it is at the end or beginning, but it is not uniformly. That means it is from the bladder or urethra. So that's sort of an analysis of the urinary coloration you need to give. Then in the swelling, when you are getting a swelling there, you discuss the possibility of many of the situations of infections. And there are sometimes a remote possibility of a malignancy, not leukemia, lymphoma, can present with autoimmune hemolysis. There in the history, you should have included a nasal block and snoring also. So any infections or whatever, throat and lymph node causing dysphagia analysis one, and noisy breathing and snoring, because some of the situations of NHL can present in both ways, either by the bone marrow suppression or remote possibility of an autoimmune hemolytic anemia. In the history part, Madam already discussed the remote possibility of a muscle disorder, especially the phosphofructokinase producing myoglobinuria with hemoglobinuria. There in the history, whether there was any weakness noticed, whether there's a motor delay, that is important. Many muscle cramps or anything suggestive of a muscle disorder in the history, you need to be considered. Okay. And in the examination, you said generalized jaundice. It's very, very, very unusual for a very severe jaundice in any of the hemolytic disorders, acute hemolysis. Unlikely for him to have a staining of the skin, palms and all, a bit unusual, even with 7 milligrams. So maybe you are making a wrong judgment of the skin and generalized jaundice part. That is maybe you are likely to be criticized. Then in the examination, always include the mediastinal percussion. In any situation of a swelling in lymph node in the neck, you should be including the medias in the clinical examination. You mentioned that in the X-ray, but the mediastinal percussion is always important. And when you mentioned about the spleen, you said the firm spleen. So you may be going into trouble because a firmness of a liver or spleen in a context, you expect in a case of chronicity or a malignancy. An acute problem, whether it is immune hemolytics or short duration, or IMN part, or an acute hemolysis, whatever, will not produce a firm spleen. So you're committing a spleen, there is a tip of the spleen only. Next moment you said it is firm spleen. Better avoid that firmness. Spleen is felt tip only. Rather than going into trouble, better not to mention the consistency. You don't expect a firm consistency there. If you are getting a firm consistency, that argues for a malignancy like lymphoma. The other situation, you can't get a firm spleen. Then in the examination, always include muscle pathology also at that stage. Of course, when you are getting a significant pallor, the possibility are hemoglobinuria or hematuria part. We have discussed the possibility of a HUS also. When there is this thing, muscle disorder is unlikely, but in that situation, examination reflexes and tone need to be mentioned. So in the CNS examination, none of the other things are relevant. Few of the HUS situation, there can be a neurological problem. Few of the metabolic problems, the muscle can be involved, I said, sir. The reflex part is important. And the evaluation of the clinical evaluation, always non-invasive and simple investigation to be completed first before you go to the thing. So urinary coloration was there. So for that, urine microscopy, albumin is important because that is the one differentiating your HUS-like state where there is a glomerular injury. So cast is there, albumin is there, microscopy, what is it? That is need to be done bedside, a simple investigation to be completed. And the hemoglobinuria or not, madam already discussed, but this one entity is spectrophotometry also may be helpful. And in the plasma, you said the centrifugation and look at the plasma, is it color? That can be estimated also. So differential diagnosis, basically, if you are getting a hemoglobin in the plasma, is the intravascular hemolytic state. We all discussed all the other possibilities. When there is a fever 10 days, you need to consider the black water fever like situation. Especially if it is a sick child, malaria is a very important thing. And the metabolic problems triggered by the fever also is one of the possibilities. So all these possibilities you considered and well discussed. All the areas you touched very well discussed the case. Thank you, Dr. Mary and Dr. Tasni.
Thank you, sir. Thank you so much for those very important, very precise and crisp interpretation and your comments, sir. Thank you so much, as usual. Sir, also over to Dr. Johnny, sir. He is also the mentor for this case. So your comment, sir.
Yeah, it's an very interesting and extensive discussion about autoimmune hemolytic anemia related condition. I really enjoyed listening to the discussions. Very well discussed. Also, Purushottam sir, thank you for that. Additional informations. And Tasni also did a reasonably good job. Thank you, Tasni. So well done. Thank you very much.
Thank you, sir.
Presented-
Thank you so much.
Presented well.
Yeah.
Released well.
Yeah,
Also
definitely.
managed.
Correct. So
Thank
over to the closing comments by Mohandas, sir.
It was a very extensively worked up case and presented well by Tasni, and all the aspects were beautifully discussed by Dr. Mary. Congratulations to all, and also to the mentor, Dr. Johnny, who is my batchmate.
Thank you.
Okay. Okay. Thank you so much for that case presentation, Dr. Tasni. Well done. You presented really well. It is appreciated by everyone. Good. And thank you so much, Mary Madam. It was really extensive, but very informative and educative both at the same time. And thank you, sirs, all of you all for joining and being with us for this case discussion. Thank you, sir. And if there are no other comments, we'll close the session.
Thank you.
Okay. Good night.
Thanks.
Good
Good
night.
night, sir. Good night.
Thank you. Good night.
Good night.
Good night.
Good night, madam.
Good night.